Now we are going to the IHC markers of molecular alterations. This is a vast area, okay, and ever improving area. Probably I checked the literature by 8 p.m. Probably there may be some change now because it is 12:30 now in US. So the IHC markers in the soft tissue tumor or any organ, they can be divided into conventional IHC markers and new generation IHC markers. And the conventional IHC markers are lineage specific. They tell whether they are arising from the smooth muscle or skeletal muscle or endothelium. Okay, for example, Soxton, adipose tissue, cartilage, and nerve, SMA for smooth muscle. So they are lineage specific markers. Whereas the new generation markers are molecular event specific. Okay, so these are all the new generation markers for soft tissue tumors. Don't worry about them. We will see pictures of all these things. Don't try to memorize them. And you can divide this table into markers that are used in fascicular pattern. Remember the 6 pattern we talked. So whenever you have markers, you divide them into markers that are positive in fascicular pattern tumors. For example, desmoid, beta-catenin, solitary fibrous tumors, STAT6, low-grade fibromyxoid sarcoma, MUC4, or tumors in epithelioid pattern, alveolar soft part sarcoma, TFE3, or tumors in adipose tissue, okay, dedifferentiated liposarcoma where MDM2 or CD4 positive. Take a picture of this. The main concept you have to remember here is they are lineage specific, the conventional markers, and the new generation markers are molecular event specific. These molecular event specific markers can be divided mainly in 6 types. Markers associated with the gene fusion, gene amplification, gene overexpression, inactivation, single nucleotide variant, and the epigenetic where there is aberrant methylation. These are all the 6 major headings under which we will be seeing the surrogate IHC markers. Why they are important? They are very, very important for the personalized treatment where we target the molecular events. Okay, and that's why they are very, very important, and that's why we pathologists should take the driver's seat in helping and guiding the clinicians and the medical oncologists to say what molecular event is there and how they can address that molecular event with the personalized targeted therapies. Okay, so under gene fusion there is a big list. Again, you take a picture of this, we will be seeing a lot of the images to cover all these things. Okay, there are 15 molecular markers associated with the gene fusion. So this is a soft tissue mass where you can see small blue cells. Okay, and those small blue cells are having some blood vessels scattered in between them, and this they have metastasized to the lung, and you can see the entrapped bronchial epithelial cells. So these are more small blue cells, and they are positive for BCAR and the CCNB3. You know, previously we might have called it as Ewing sarcoma, but since now it is associated with the BCAR and CCNB3, it is a BCAR CCNB3 sarcoma. Whereas this tumor, it's a renal mass and it has lobules of clear cells. Okay, and some of the cells are spindled out with scattered blood vessels. So this is clear cell sarcoma of the kidney. Again, that clear cell sarcoma of the kidney is positive for BCAR. So it's a clear cell sarcoma of the if I told clear cell carcinoma, excuse me, it's a clear cell sarcoma of the kidney. So those are the 2 tumors that are associated with the BCAR. Let us see this composite picture. Here it is self-explanatory in the HNE itself. A lot of desmoplasia with this nest of small blue cells. So this is desmoplastic small blue cell tumor. And these are characteristically positive for Wilms tumor marker, WT1, in the C terminus. Okay, they are nicely nuclear positive. And here the cells are arranged, small blue cells again, the cells are arranged in some of the cells in the center is gone. Okay, so it is trying to show a alveolar pattern, and the PFM.2 is positive in the nuclei. So this is a classic marker for alveolar rhabdomyosarcoma. And this tumor shows some squamous epithelium and may show some respiratory type of epithelium. And this is having very cellular tumor, and those cellular tumor looks like falling under fascicular pattern. Okay, and whenever you do fascicular pattern tumor markers, and this tumor is positive for S100 and SMA. Okay, neural and smooth muscle. So that's why it is known as biphenotypic, and they are characteristically positive for PAX3. So they have definitive diagnostic terminologies because of these immunohistochemical markers that highlight the molecular events. So we already talked about desmoplastic small round cell tumor, alveolar rhabdomyosarcoma, and this biphenotypic sinonasal sarcoma, okay, which are characteristically PAX3 positive with biphenotypic expression of neural and muscular markers. So these are all the markers we covered so far in the gene fusion: CCNB3, BCOR, WTC terminus, PAX37 FOXO1. That's the marker for alveolar rhabdomyosarcoma, and PAX3 for biphenotypic sinonasal sarcoma. Coming to this composite picture, you see the spindle cells with hemangiopericytoma-like pattern. Previously, they are called as hemangiopericytoma, but now you know hemangiopericytoma is gone and it is replaced by solitary fibrous tumor that will have nice STAT6 positive. Okay, so in the H&E you have to give it is a spindle cell tumor or cellular spindle cell tumor with staghorn shaped blood vessels. That's the description in the H&E. And IHC STAT6 positive, you can confidently say it is solitary fibrous tumor. And this picture shows hypo and hypercellular areas, lot of spindle cells, fibroblasts like cells, and that are positive for ALK and ROS1. And most of you might have got the diagnosis. It is inflammatory myofibroblastic tumor with the characteristic ALK and ROS1 expression. This tumor, again, it shows spindle cells, hypercellular tumor, and that are positive for pan-Trk protein. So this is again a molecular diagnosis or H&E based molecular diagnosis: solitary fibrous tumor, inflammatory myofibroblastic tumor, and N-Trk rearranged spindle cell neoplasm. This you can see biphasic pattern. Okay, epithelial cells, epithelioid cells, and stromal cells. Here it is more of fascicular pattern spindle cells, and they are positive for SS18 and SSX. Does any one of the attendees want to answer what is the diagnosis of this tumor? Madam, who is the first one who answers, madam? You can read out the name so that we can just clap for that particular person. Anybody typed in the diagnosis?
Sir, is it Manoj Kahar, synovial sarcoma?
Super, Manoj. Good.
And also Ankita Hebbar, synovial sarcoma. Then Dr.
Good.
Nimedita, synovial sarcoma.
Super. So it is a synovial sarcoma. Now it has a very characteristic nuclear marker for SS18, SSX. And how do you remember this? Remember the translocation X18. So this is synovial sarcoma 18 and synovial sarcoma X. Okay. So there is you have to simplify. Some of them may have very logical explanation. Some of them may not have any logical explanation. And those non-logical explanation, you keep it as your key for your mobile phone. And these things X18 you already know, so you don't have to remember. It is synovial sarcoma 18 and synovial sarcoma X. So this is the table that tells what all the tumors we have covered. In the pan-Trk, the classic example is infantile fibrosarcoma. And I showed you the N-Trk rearranged spindle cell neoplasm. They are molecularly related. Coming back to this composite picture, this is hypocellular tumor. It shows myxoid areas, and some of the cells show nice intracytoplasmic lumina, like a lobular carcinoma on the breast. But these are all spindle cell tumors. We are talking about soft tissue tumors. And very nicely, they are CAMTA1 positive. And this one looks like a leiomyoma, isn't it? Fascicular pattern. So whatever the pattern, you make the differential diagnosis, and this tumor is positive for FOSB marker, and this is alveolar pattern, and this tumor is positive for TFE3, and this is more like myxoid with a lot of curvilinear blood vessels, some adipose tissue. So HNE wise, this looks like myxoid liposarcoma, and the DDIT3 is positive nicely. Now let us see the diagnosis depending upon these markers. The CAMTA1 is a very good marker for the epithelioid hemangioendothelioma. The FOSB is diagnostic of pseudomyogenic hemangioendothelioma. The vascular markers are also positive. Muscle markers are sometimes positive, but most of the time they are negative. That is why it is known as pseudomyogenic. And FOSB is a very characteristic marker for pseudomyogenic hemangioendothelioma. TFE3 positivity in alveolar pattern is alveolar soft part sarcoma, and DDIT3 positive is very classic of myxoid liposarcoma. So these are all the markers we covered so far. So now we are done with the fusion markers. So gene fusion, there are 15 markers, you please remember. This composite picture shows a lot of inflammatory cells and a few very large pleomorphic cells. Take the smallest cell and take the largest cell, more than 3 times enlargement. Lot of inflammatory cells. Previously on the HNE, it might have diagnosed as inflammatory MFH, but this CDK4 and the MDM2 are very nicely positive, and that is very classic of dedifferentiated liposarcoma. Okay, and as I told you, it may look like inflammatory MFH, but because of these markers, now they are reclassified into dedifferentiated liposarcoma. These are markers of liposarcoma. So this is one of the amplification marker. In addition to well differentiated and dedifferentiated, it positive in atypical lipomatous tumor, intimal sarcoma arising in the major blood vessels, and surprisingly they are positive in low grade central osteosarcoma and paraosteal osteosarcoma. But we are talking about only soft tissue tumor. These are like out of syllabus. There are some bone tumors I may be talking about it, but you just keep it in mind, but they are not today's syllabus. Small blue cell tumor. Okay, previously we called the wings. This tumor is positive for NKX2.2, whereas this tumor is positive for ETV4. The NKX2.2 positive marker tumor is Ewing's sarcoma, and ETV4 is a classic marker for CIC rearranged. And remember, the CIC rearranged is having a poor prognosis. In this composite picture, you can see chondroid areas and poorly differentiated areas. And even in HNE, you can make it as a mesenchymal chondrosarcoma. And the NKX 3.1. This is a surprise. I just learned it last month in Twitter. By the way, Twitter is one of the best way to learn pathology. I kindly request all of you to spend 15 to 30 minutes every day in Twitter, where you can learn a lot of new things and you hear it from the horse's mouth, because the research what they are doing, top scientists like Jason Hornick, he will put by himself, today this is the finding we got. So you will be very much updated by following the Twitter. And the you start just following 3 people, and my name is not in that 3 people. The first one is Gerard Garner, second one is Sanjay Magobati, and third is Cameron Mirza. Okay, those are all the 3 people I follow in Twitter, and I follow a lot of other people also. To start with, these 3 people are very good. You can learn a lot of them. NKX 3.1, supposed to be marker of prostatic adenocarcinoma, seems to be a very nice marker for mesenchymal chondrosarcoma. This one shows a lot of sclerosis and small round epithelioid cells. So this is a specific tumor that is positive for MUC4 marker in the cytoplasm. Okay, And this tumor, you all know, this is again a spindle cell hypercellular tumor that is nicely positive membranous and cytoplasmic positivity for DOG1. You all might have got the diagnosis. So NKX 3.1 is marker for a mesenchymal chondrosarcoma, MUC4 for sclerosing epithelioid fibrosarcoma, and DOG1 for GIST. Again, many people make the diagnosis of GIST on H&E. In the H&E, it is one of the differential diagnoses. You need DOG1 or CD117 or platelet-derived growth factor positivity before calling it as or labeling it as GIST. So these are all the markers we covered, and they are all the markers of overexpression. This composite picture, hand mass, these are more like pink cells, large pink cells. Okay, all of them are having large pink cell. Okay, that's one of the concept you have to learn. Large pink cells, some of them we call epithelioid, some of them you may call rhabdoid. Okay, when the nucleus is situated in the center, large pink cell, it is epithelioid. When the nucleus is pushed to the periphery, it is rhabdoid. And I call my PGs and ask them, what is the marker positive in rhabdoid? They will immediately tell desmin. Okay, desmin is negative in rhabdoid. If it is positive, why are you calling rhabdoid? Oid means resembling. They resemble skeletal muscle, but they are cytokeratin positive. Okay, that's why it is called as rhabdoid. Okay, this is a hand mass, and this shows loss of this marker, SMARC-B1, or also known as INI1. And this INI is preserved in the background lymphoid cells and some of the endothelial cells probably, but the tumor cells, they are absent. In this epithelioid tumor, there's a history of thoracic mass, and SMARC-A4 is negative. Again, background cells are positive. In this uterine mass, SMARC-A4 is negative. And in this gastric mass, the SDHB, okay, succinyl dehydrogenase B, is negative. It is preserved in some of the smooth muscles of the stomach and some of the inflammatory cells or endothelial cells, but the main tumor cells are negative. So these are all inactivation markers. So depending upon that, you give the name. Epithelioid sarcoma, more commonly seen in extremities, INI1 negative or SMARC-B1 negative. Thoracic mass with SMARC-A4 negativity is known as thoracic SMARC-A4 deficient undifferentiated tumor. In the uterine, it is confused with the poorly differentiated endometrioid carcinoma, but it is now renamed as, because of the molecular event, as SMARC-A4 deficient uterine sarcoma. And the gastric mass which are deficient in SDH2, SDHB, is epithelioid GIST. So as I told you, these gene inactivation tumors are having epithelioid or rhabdoid morphology. So when you have epithelioid and rhabdoid morphology, you put these markers of gene inactivation and you name them accordingly. So these are all the markers of inactivation. The last but one, again, this is out of syllabus. This is a femur, pelvic bone, destructive lesion in the femur. It shows osteoclast like giant cells and many another osteoclast like giant cells and many stromal cells that are malignant looking. You can see a very atypical mitosis. And these tumor cells are positive for a marker called G34W. I think here glycine is replaced. And it is one of the markers of single nucleotide polymorphism, SNP. Okay, so this is so classic for so diagnostic of giant cell tumor of the bone. They are negative in all the other giant cell rich bone and soft tissue tumors. Even in giant cell tumor of soft tissue, they are negative. They are very specific for giant cell tumor of the bone. Please remember this, because that's one of the university questions, giant cell rich tumors of bone. All other entities are negative, like aneurysmal bone cyst, parathyroidism, they are all negative. The G34W is positive only in the giant cell tumor of the bone. This is a core biopsy from another epiphyseal lesion. You can see the bone, you can see the cells, and these cells are nicely positive for K36M. Okay, and this is a marker that is diagnostic of chondroblastoma. Okay, yeah. So giant cell tumor of the bone G34W and chondroblastoma K36. Yeah. So these are all the single nucleotide variant. And finally, we are coming to a tumor. This is again blood vessel. These are all fascicular or epithelioid tumor cells. So there's a wide differential diagnosis. And when you do a marker called as H3K27ME3, this I learned from Jason Hornick. Okay, he pronounced it so nicely. I remember them by heart now. H3K27ME3. And I think there's some methylation in H3K27 level. Histone 327 level undergo methylation. That's what I remember, but you please kindly check. And they are lost in the tumor cells. They are positive in the endothelial cells and some of the inflammatory cells in the background. And when they are lost, it's a very diagnostic of malignant peripheral nerve sheath tumor. Okay, please remember loss of H3K27ME3 in MPNST. That's a aberrant methylation marker that is lost. So that brings the end of all the markers. And there is one concept you have to remember. We saw a lot of translocation associated sarcomas like synovial sarcoma, Ewing sarcoma, and they have uniform cellularity, no pleomorphism, no atypical mitosis. Okay, sometimes they may be mistaken for lymphoma, but lymphoma will have a lot of mitosis. So when you have uniform small blue cells without pleomorphism, without any atypical mitosis, think of translocation associated sarcomas. That brings this slide for you. And these are all the translocation associated small round cell sarcomas. Take a picture of this. So that's the end of this hour's discussion. So the take home message, summary of WHO, please remember the 12 major headings. And please remember this table. How will you differentiate benign and malignant? It's a junction between the tumor and normal. Just whenever there is 2 by 2 table, just remember one. Okay, in benign, it's a well delineated tumor, mildly hypercellular with mild pleomorphism, no necrosis, low mitosis, no atypical mitosis, no apoptosis. That is benign. All the opposite is for malignant. If you try to remember both, you may get confused. So just remember one column. That will help you to remember better. And always follow set of criteria and triple test. Unfortunately, they talk about triple test in breast, where the clinical, radiological, and pathological correlation should be there. It should be followed in all tumors now. As Manoj told, nowadays we are getting more and more fragmented pieces of tiny tumors, and the less the tumor they give, the more the material they want to know. So we have to apply clinical and radiological. And radiological image is very, very important. And I used to tell radiology is part of pathology now. Okay, that's part of gross examination of the specimen. And whenever there's a problem, please call the clinicians. Okay, calling the clinician will solve the problem, or take the clinician to the radiology and have a small tumor board kind of discussion that will bring the diagnosis. And all tumors cannot be classified. Clinical setting and H&E, you have to follow a differential diagnosis, and special techniques, you can use them as a tool to come to a definitive diagnosis. And IHC markers are one of the special techniques, and they are mainly classified into conventional lineage specific and new generation molecular event specific. And they are very important because they help in the targeted therapy. In case of any difficulties, please go back to H&E. Okay, don't make only the diagnosis by IHC markers. So the references is the final part. The first reference is the Ensinger and Weiss soft tissue tumors. This is Dr. Ensinger. This is Dr. Sharon Weiss. This is Dr. John Goldblum. And this is Dr. Andrew Flaw. And these are all the main editors. Why I am putting the pictures? You may see them in conferences or virtual or real conferences. So you can go and talk to them. But when you see Ensinger, you are in a wrong place because he is in the right place now. So the second reference is the Blue Book. Third is Google Images. Only 10% of them are my images. All the others, I took it from other references in Google Images. Pathology outlines, single, if you are able to read only one source, please read pathology outlines. Many of the conventional professors, pathology professors may be angry with me, but that's one of a beautiful site. And again, I am not financially connected. By referring that, I am not getting any money. And the fifth and sixth, they're the articles that formed the backbone of today's discussion. Okay, the 2020, the first one is by Choi et al. 2020 WHO classification, selected changes and new entities, and all the immunohistochemical markers I talked about associated with molecular events are from Anderson et al.'s paper. Okay, they are recently 2021 papers, both of them. Take a selfie of this because you may be interested in these papers, and I think I have given it in my handout also. So these are all the people we have to thank, because these are all the people who sat together and put their knowledge and come up with the 5th edition of the Blue Book. You can see Jason Hornig there, Andrew Flop is there, Christopher Fletcher is there, Dr. Mahul Amin, one of a proud Indian pathologist, is there. Rest of the people, I don't know, I think this is Dr. Thompson Lester from the ENT. Okay, so we thank all these people also for putting a nice book for us. So with that, I want to end this discussion. The only way to do great work is to love what you do. That's what from my mentor, Steve Jobs. Thanks a lot and have an awesome time.